Thank you very much. So now I think we have heard quite a lot about iliac and complex iliac disease. We move now one level down to the common femoral, and we will go directly to the cath lab. I think Prakash already waiting with the next case. I just want to make you aware, we have here for you available this little booklet, this live case guide. So this has been something which was quite useful over the years at our meeting, where we've put case information together and also some of the procedural steps as they were planned. So with that, PK, we are with
Hi,
you.
Dirk, how are you? I wanted to really welcome you to the cath lab, and I want to introduce who we're going to do the cases with. This is Dr. Vishal Kapoor next to me. He's the Associate Director and the Director at Mount Sinai West. This is Dr. Farhan Majid, our Endovascular Fellow. That's Jennifer Chan, one of our nurses. Marichu Malloy behind me, and Ray Lascano, our interventional nurse practitioner. So we prepared a phenomenal case and a very controversial case of common femoral artery disease. As we discussed, we want to be able to discuss some of the controversies that we have, and technically, this definitely has a lot of discussion points. So without further ado, I'm going to ask Dr. Majid to present the case.
Good morning, everybody. So this is an 83-year-old female with a history of hypertension, hyperlipidemia, and previous tobacco use. The patient presents with one block, lifestyle-limiting right lower extremity claudication for the last few weeks. Rutherford grade 1, category 3, Fontaine 2B. The claudication occurs at about 50 feet. Otherwise, there's no rest pain or ischemic ulcers. Next slide, please. As you know, the past medical history, the ejection fraction is normal, and she's got some risk factors. Next slide. On appropriate medications, including aspirin and cilostazol, as well as a statin and beta blocker. The patient has a long previous history of smoking, but quit 20 years ago. Next slide, please. Examination reveals normal vitals. Extremities reveal a 1+ DP and PT pulses in the right lower extremity. Left is normal. Labs you can see there, hemoglobin is 10.8 and a creatinine of 1.4. The patient did undergo ABIs. Resting ABIs showed a right ABI of 0.73 and a left ABI of 0.91. The patient underwent exercise ABIs and at 1 minute and 30 seconds had reproducible calf and thigh pain. The patient, the ABIs with exercise, the right one you can see would drop to 0.55 and the left one stayed the same. Next slide, please. So here's the angiogram. You can see the iliac system is without significant disease. Next slide. You can see there is significant disease at the common femoral that PK will talk about further, but there may be some dissection or thrombus in that area. Next slide. And of note, the patient denies previously having any groin procedures such as a cardiac catheterization or anything else. Here you can see the SFA has just some mild disease, and at the level of the popliteal there is no significant disease. Next slide, please. Below the infrapopliteal, the AT and peroneal are patent, and you can see that the PT is occluded in the mid portion with distal reconstitution. Next slide. Here again, the distal level, the AT and peroneal flow well, and there's distal reconstitution of the PT. Next slide, please. And at the level of the foot, you can see filling of the dorsalis pedis and reconstitution of the PT. Next slide. So in summary, this is an 83-year-old with hypertension, hyperlipidemia, and tobacco use who presents with severe right lower extremity claudication and an abnormal ABI of 0.73 that got worse with exercise to 0.55. Peripheral angiogram reveals severe right common femoral stenosis, and the plan is to perform right CFA intervention. PK?
Thank you for that nice presentation. So Dirk, as you know, there's a lot of controversy with this particular area. Go to the next slide. So I wanted to just open it up to the panel, and you can see the angiogram here. And it was very perplexing to us that she denied having any common femoral artery intervention or any sort of access point at this area. So we went ahead and did an intravascular ultrasound. Can you play the IVUS, please? So if you see the intravascular ultrasound, we went ahead and showed it. You can see here we're doing a pullback from distal to proximal, and once they play it, you'll see. Can you run the IVUS, please? IVUS? Sorry about the delay. So when you can see this, there you can see the pullback. The artery is really very, very healthy looking. And you have some areas of plaque. Obviously, she does have PAD with the occluded posterior tibial, some diffuse calcification, and then you can see there seems to be a rent in the artery with a dissection. And then you can see followed by what looks like possibly thrombus or occlusive disease, explaining the symptoms that she has. So we felt that the controversy here was really to discuss the endovascular approach of common femoral artery disease here versus how the panel would manage it, and we can explain our rationale to why we are going to go ahead and do endovascular.
So anybody who wants to comment? Dr. Babayev?
Well,
Good morning.
Yeah. Okay. Go ahead.
Good morning, PK. This is Anwar. So it's actually very interesting. It does look, if you look at angiography only, it does look like patient had a procedure before. It just angiographically looks that way. But I think the best approach in this case, at least this is what I would consider doing, is a directional atherectomy followed by drug-coated balloon.
Now, one of the controversies, Anwar, that we discussed, can you turn that off, please? Or turn it lower? One of the controversies that we discussed is, the data with surgical intervention, other than Dr. Zeller's data, really shows superiority to other forms of intervention. But here, what we were considering was there was no profunda involvement, and there's no osteal SFA involvement. It's really a body of the common femoral. So what we felt was the same thing, that we're going to go ahead and do directional atherectomy with DCB. And so we did an IVUS measurement here of a 7 millimeter. It came out to be a 7 millimeter vessel. And the second thing is, when we do directional atherectomy, I'm curious on Dr. Zeller and Dr. Rumbach's comments. If you do have a dissection in this area, what would you do here? So we're just going to start doing directional atherectomy with the Silverhawk. Just for the audience, we put a distal protection device with a filter in the SFA. And don't ask me why we didn't protect the profunda. We chose the SFA. And I don't know whether there's a right or a wrong. And we're just going to go ahead and get started while you guys discuss.
Yeah, so to address the idea of what to do in a bailout, the data on this is relatively mixed.
Not yet.
Very limited experience with stents in this location. Obviously need to be nitinol self-expanding stents. One study showed they're superior. Most studies suggest they're inferior, and they interfere with subsequent interventions in that area. So by all means, I think you're right to avoid a stent. Your strategy is great, exactly what we would do. Directional atherectomy, and then drug-coated balloon. Interestingly, we've used some cutters in this location as well before drug-coated balloon angioplasty with some satisfactory results.
So PK, I think your choice of protecting the SFA makes a lot of sense, because if you embolize into the profunda, you're probably going to pick off some branch of the profunda, which would be clinically unimportant most of the time. Whereas if you go downstream and then clip off one of the remaining tibial vessels, the patient could have worse symptoms. So I think that makes a lot of sense.
I think it's important to choose the right cases to do this, and I think this is, even as a surgeon, I can say this is probably a good case to try this. If it was heavily calcified, I would definitely be hesitant doing something like this, just because if you do have a dissection, then it might be a little bit challenging.
So Tom, I know you have tremendous experience. I don't know if you're on the panel with this. I'm just curious in terms of what you would do here. Do you say?
Well, basically, I would do the same as what you are doing now. Plaque excision, that would be my first choice, and followed by DCB. There's some calcium, but it's not severely calcified. And I believe plaque excision, meaning directional atherectomy, is the right way to treat this. On the other hand, this is an old lady, so if there would be an indication to use a stent, nitinol stents are performing very well in this position. A short stent, 2 centimeters only, this will maintain patency over a decade without any problems. And there's a French study which already compared stenting with surgery, and they have shown equivalent outcome for stenting.
So the question, would you use a drug-coated stent or just regular nitinol stent here, Tom?
Regular nitinol stent usually.
Okay.
Yeah. I wouldn't recommend to use the Supera stent, because just in case, if you would need to get access through the groin here for coronary procedures or whatever reason, it's easy to insert a sheath through a traditional nitinol stent, whereas if you have a nicely expanded Supera stent, it's not so easy to get a sheath across the struts.
This is not my experience, Thomas. I have experience now with the VMI common femoral artery study, where we expect the results in the upcoming link 2018. We are collecting now 6 months data, And so in 100 patients so far, there were no problems with the supera in the common femoral in terms of patency. Some of them also had a puncture, repunctured because of other procedures. And it's quite easy to repuncture the nitinol wires, the woven structure of a supera. In my opinion, less risk for damage than compared to the conventional nitinol stent. So I don't have this experience. And I know people that are implanting superas in AV fistulas. So the nephrologists, they like to have the supera over there. They feel it very well, and they can puncture it 3 times a week without any problem. So repuncturing, in my opinion, is not an issue. My fear here a little bit to implant a supera is that I'm not sure if there is some thrombus. So we know that you have to do a perfect vessel prep before you implant a supera. And perfect vessel prep in this situation can create distal embolization. And then I'm always struggling with the fact as a surgeon, the deep femoral artery is the holy artery for us. So I agree that we need to protect this SFA and the below the knee vessels, but I'm also in doubt if we can allow just distal embolization to this deep femoral artery. So actually you should use 2 filters, or what do you think on this?
Well,
PK, would that be technically feasible in your eyes to have 2 filters?
I think with directional atherectomy, I think all of you would agree that it's very difficult to have 2 filters down. The only thing that I want to show you here, what we've done is, before I go up with the DCB, is we did another IVUS. Can you show the IVUS, guys? So we were able to clear this out. But and you can see we were able to do a pretty good job here, Dirk, in terms of cutting most of the plaque away. Again, the directional component is not the best here because of the tortuosity. I even pulled the sheath back, if you notice, to get better apposition of this. But clearly, we have a better lumen than we did before. But to really ask the question and to push the faculty is, you know, this is an isolated without profunda involvement. So if you add a common femoral lesion with profunda involvement and just a focal common femoral lesion, should that go to surgery or should that be done endovascularly? Our reason for doing this endovascularly is that there's the body of the common femoral. We felt that we would not disrupt the ostium of the profunda, and we felt that we could probably bail out with a stent here. But my worry is if these lesions are performed endovascularly, when the profunda is involved, does that change your algorithm? And that's kind of the reason why we wanted to talk about this.
So maybe we ask Kohn, as a surgeon, you have the right of first refusal here.
Often.
Thank you very much, Dirk. Now, it's quite clear, I fully agree with you, PK, that if there is an important involvement of the femoral bifurcation with extending of disease into the profunda, and there is not really an absolute contraindication for surgery, for me, this is going direct to the operating theater, a small incision in the groin, doing a very nice bifurcation and arterectomy can be done under the local anesthesia, and the results in terms of durability are extremely good. So yes, this is for me a surgical indication.
So let me play devil's advocate a little bit, if we will, since we're all talking about surgery. We've treated quite a few of these femoral bifurcation lesions in elderly patients with substantial surgical comorbidities, and the results have been quite favorable. It's generally a double wire technique, a little less atherectomy if you have to use 2 filters, a little more drug-coated balloons in that particular case. And we've had, very nice results. Again, sort of like I showed in the iliac, you may not always get an optimal result, but you get a clinically relevant result, and these patients do quite well.
So the one question I have for the panel is, in this kind of lesion where she denies having a procedure, so although I agree with Dr. Anwar that clearly this does look like an injury from a catheter, but is this appropriate to use a drug-coated balloon here? Because of the fact that there's really not much, how can you say, atheroma, or what looks like a real atherosclerotic process going on in this common femoral.
Well, I think there's enough of an atherosclerotic process that it does make sense. I think that would be a really good choice in this patient, drug-coated.
So that's what we have here. We have the impact Admiral balloon. We chose IVUS measurement-wise, it was a 7. So if you believe in the 1-to-1 balloon artery ratio or a little bit more, I think we hit that. We chose a 40, which is the smallest size that they have, and we're now inflating it to nominal pressures, and you can see by fluoroscopy there is no waste. And so therefore we're left it up for 2 minutes, And now we're going to walk it out with the filter in place. And just show you our filter. So we also use the Spider FX filter here for this particular case. And you can see here as we walk it out, I'm just going to hold the sheath and we'll take a picture and do a quick IVUS.
So PK, one thing after you did the atherectomy, maybe you could have put a wire down the profunda just to protect that, as you know, as mentioned before. It's
but we weren't going to actually touch the profunda with the balloon, so I don't believe we've crossed the ostium with the profunda with the balloon, although we'll find out now. So there we go. So is this acceptable, not acceptable? Do you leave this? Do you guys, let me do an IVUS to give you more guidance.
I think it looks good angiographically. I don't think you should touch it. I think you're done.
And you could also put a small catheter down there, see if there's any pressure drop off with or without nitro, and that would kind of complete the picture.
And this is drug-eluting. Dr. Zeller published common femoral data, I think atherectomy, and it was just plain balloon angioplasty afterwards, right? With a pretty good patency rates afterwards. And I don't remember what was the follow-up, how long that was.
Well, I will show up-to-date data during my talk in a couple of minutes. The outcome is exceptional, and I believe it will be shown that we are equivalent with endovascular approach to
Ready
surgery.
for pullback?
Yeah.
Record, please. Yeah. So Dirk, I don't know if you can see the IVUS. We're just doing a live IVUS here for you. I just want to get obviously the experts in the panel to help us on whether they would stent this or leave it. You can see here there's a dissection flap right there that we saw.
Well, PK, just to maybe rephrase this question. I mean, from the very beginning, this was very focal eccentric disease, as we typically see it in the common femoral. Sometimes it's more calcified. This one here was not so calcified. Yes, so I think the approach with directional atherectomy to remove as much as possible makes a lot of sense. I think you probably managed to remove a large part, but certainly not everything, as we can clearly see in the IVUS. So now, I mean, the question is really, if we go for drug delivery, is DCB the best option, or would a short drug-eluting stent be the better option because it could deliver a drug and at the same time provide an additional scaffolding? So maybe that's something for the panelists again to address.
I'd say this looks pretty good, right?
Yeah, I think if you stop, I mean, if you proceed and things become worse, it becomes harder, as you know, and if you stop now, I think it gives us options as surgeons to, if we need to go back in, to really correct this without having a stent sitting in the way. It almost looks like she may have embolized at some point into the common femoral. I mean, because the rest of the aorta looks, I mean, the rest of the vessels look pretty clean. So I wonder if she's had some embolic event in the past, or has plaque upstream or AFib or something. So
no, there is a dissection.
Whether that might represent the posterior tibial occlusion, because the vessels elsewhere look pretty
beautiful.
Good.
Yeah,
so it could be that whatever's going on in the common femoral could have embolized to the PT as well.
I'm not sure actually that drug-coated balloon and here is, we're all going to do that, of course, but there is no data that is better than plain balloon angioplasty after directional atherectomy. We also published a series of patients treated with directional atherectomy and plain balloon angioplasty after angioceal complications. We had, and with follow-up of 16 months with the perfect patency rates. So I'm not sure how much difference that the drug-coated balloon will make, but we feel that it's probably better than the plain balloon angioplasty, but there is no proof probably yet at this time.
Well, this patient would be excluded from every trial.
Right.
So I think that, you know, the reason we presented it, I think we achieved our goal. I mean, there's tremendous controversy in terms of what to do in these patients. You know, I really wanted to, I know Dirk and I discussed this, is really how do you deal with the common femoral when you have no bifurcation involvement? I think bifurcation involvement forces your hand to possibly consider surgery more. But in today's technology, and that's why it's important for Dr. Deleuze and Dr. Malik to tell us the surgical perspective, whether this is a rational approach if we avoid putting in a metallic, or maybe that's not even a criteria here, to get this open. So that's one of the reasons why I think we wanted to really discuss this.
Yeah, PK, I think that was really a very interesting case, very thought-provoking and stimulating, and clearly you're touching here one of the last frontiers of vascular intervention, if we try to push the envelope of endovascular procedures. So with that, thank you very much to you and the team for this excellent presentation.